Tissue integrity. The exemplars in this particular module are pressure injuries and herpes zoster, with several interrelated concepts that include perfusion, gas exchange, nutrition, sensory perception, mobility, fluids and electrolytes, thermoregulation, elimination, pain, and infection. Tissue integrity is defined as the state of structurally intact and physiologically functioning epithelial tissues, such as the integument. This includes the skin and subcutaneous tissue, along with the mucous membranes. The term impaired tissue integrity reflects varying levels of damage to one or more of those groups of cells. And a break or disruption in the skin integrity can lead to potentially dangerous or even life-threatening issues. So let's do a quick review of what's going on in the skin. We have epithelial cells that cover nearly every internal and external surface of the body, and this helps protect the body from the external environment, absorbing needed substances, secretions into the body cavities, and excretion of wastes from the body. It consists of two main layers, which are the epidermis and the dermis, but the subcutaneous or fat tissue can be considered a third layer. Mucous membranes are epithelial tissues, and they secrete thick, slippery mucus that helps protect the body from infection. Now, the skin has several functions. It protects underlying tissues from infection and trauma. We have the perception of touch, pain, pressure, heat, and cold from the skin. The skin helps regulate the temperature through vasoconstriction and through vasodilation. The skin will synthesize vitamin D from sunlight, and perspiration will also help rid the body of toxins. There are a few cultural considerations. We know that variations in skin color is due to the amount of melanin that is located in the skin. For example, the African Americans have a darker skin color, and this is due to the amount of melanin they have. There's also going to be post-inflammatory hyperpigmentation and vitiligo. We should always assess darker skin for oxygenation through the buccal mucosa, the lips, the tongue, the nail beds, and the palms of the hands or soles of the feet, because this area is going to be pretty much the same in everyone regardless of the skin color. With the older adult, we're talking genetics here, not gerontological, we have a risk of developing particular skin disorder that will increase when a close relative also has that disorder. So genetically, we may come down with epidermolysis bullosa, ichthyosis, or albinism. Risk factors for skin disorders include our age or developmental level, the amount of sun or environmental damage that has accumulated over time, any comorbidities that we suffer from, our genetics, our skin color, impaired cognition or sensory perception, if we're very thin or very obese, if we have fluid loss or overhydration, If we have liver or renal disease or failure of those organs due to a toxin buildup in the skin. Particular skin diseases. Lifestyle variables such as what chemicals are we exposed to routinely? How many piercings do we have? Do we have tattoos? Immobility. And therapeutic measures such as the wearing of brace or the application of casts, the use of radiation or some medications. Potential problems from impaired skin integrity include a risk for infection, imbalanced nutrition, acute or chronic pain, impaired physical mobility, impaired skin integrity, and ineffective peripheral tissue perfusion. So across the lifespan, tissue integrity is going to vary. With newborns and children, we know their skin is thinner, it's more permeable, and they have less subcutaneous fat. This will lead to a greater potential for fluid loss and less effective temperature regulation. And the texture of the skin is usually smooth and dry. With the adolescent, the apocrine glands are going to begin to function, and this is going to result in a more oily skin and potentially acne. The pregnant woman, they also have increased sebum production, or the oils. They have increased melanin that can lead to dark spots, such as the linea nigra, which is a darkened skin down the middle of the abdomen. They may develop the stria, also known as stretch marks, or have an outbreak of red, itchy spots. The older adult, their skin becomes thinner and they have a decrease in strength, moisture, and elasticity. There's also a decrease in underlying supportive structures, such as lean body mass and subcutaneous fat. And they may also have diminished perception of pain, so they can become injured more easily because they're not experiencing the same level of pain. They may have reduced arterial and venous blood flow. They have slowed hair and nail growth. And their skin may be rough, dry, and itchy due to a decrease in sebaceous gland activity. So to promote healthy skin, we have to look at primary prevention, and that starts off with hygiene, adequate nutrition, protection from and appropriate protection from sun exposure, such as avoiding activities in the sunlight between 10 and 4, especially in the summer when the sun is strongest. Seek shade if you have to be outside, especially during those hours. Cover the skin and consider a hat with a wide brim and the use of sunscreens. And this also includes sunglasses with appropriate ultraviolet protection. We should also educate on burn prevention and dermal ulcer prevention. With secondary prevention, we're looking for early detection of potential skin cancers. The most serious skin cancer is going to be multiple myeloma, or melanoma, metastatic melanoma. We also have basal cell carcinoma, which is a skin cancer that rarely metastasizes. And then we also have squamous cell cancer, all of the skin. So when we're looking at the melanomas, we have a mnemonic that we can use, A, B, C, D, E. A will be it's asymmetrical. It's not perfectly round or uh, have a perfect shape. It's going to be very asymmetrical. The borders are going to be very irregular. The color of the lesion is going to vary. It may be dark in one area, light in another, etc. And the diameter is going to be larger than a pea or at least 1/4 of an inch. And then E is the lesion itself is going to continually be evolving or changing. Then we look at modifiable risk factors, meaning they're factors that we can change. Maybe a compromised immune system can be changed by getting rid of specific medications or taking specific medications. We can halt the exposure to irritants and allergens and make sure that we're appropriately treating chronic illnesses, and then teach our clients to be involved in self-examination. When we're doing our assessment, we need to ask about the history of any allergies, skin problems, previous bruising, their overall general skin condition, what skin lesions do they have, and do they have unusual healing of any sores? Then we also need to inquire about use of home remedies and any alternative products they might have used. When we examine the client with inspection and palpation, we're looking at the skin color distribution and the skin turgor. We're looking for erythema, that redness, dryness, rashes, lesions, or areas of hypo or hyperpigmentation. We're looking for the presence of edema or lesions. We're paying attention especially to skin folds, such as underneath the breast, underneath the arms, or underneath abdominal folds. Looking at the perineum and those bony prominences. Make sure that you remove socks, braces, etc., so you can inspect the skin underneath. Good lighting is required for inspection. We should also palpate the texture and temperature of the skin. And when we're assessing that skin turgor, we should assess it on the clavicle, the sternum, or the forehead. And your text also says to maybe use the forearm. However, do not use the back of the hand, especially in the older adult, because as they begin to lose elasticity in their skin as they age, then that's going to begin to give inaccurate results on hydration. Then we need to assess wounds, and we should do weekly measurements. We're assessing the peri-wound, the wound bed tissue type, the edges. Is there undermining or tunneling? Is there any exudate? If so, what kind is it? How much, and does it have an odor? Is there any induration, warmth, erythema, or pain? Excuse me. Different diagnostic tests that we can do would include maybe skin biopsies, doing cultures of tissue samples or wound drainage, identification of any infections, and this would be done from wound cultures, identity of any allergies, and that would be done from allergy testing such as patch testing. We can also use a Woods light, which is basically a black light, and that can be very useful in identifying some fungal infections. And then, of course, we need to look at our labs. We're looking at hemoglobin, our blood coagulation, our serum protein or albumin, and looking at wound culture and sensitivity. Treatment would involve wound management and appropriate selection of dressings, prevention of infection, adequate nutrition. We need that good protein. We need to also consider our vitamin C, and if we have a wound that stalls, in other words, its healing slows down, then we can add some zinc. With surgical management, we're looking at excising a lesion, debriding a wound, or maybe using skin grafts. And there's a ton of pharmacological agents that could be used, such as topical corticosteroids, anti-acne medications, antibacterials, antibiotics, antivirals, anesthetics, creams, ointments, lotions, or chemotherapy agents. And then we also look at the complementary health approaches, such as the supplements with the vitamins, minerals, and herbs, and understanding that there is insufficient evidence to recommend or dismiss the use of some of these treatments. Skin issues can be caused by trauma, injury, decreased perfusion, allergic or immunological reactions, and this would include dermatitis, and dermatitis would include allergic or irritant. And then we also have psoriasis, infections and infestations caused by bacterial, fungal, virus, or parasitic agents, and lesions such as skin growths, vascular lesions, and tumors. Wounds are classified in a variety of ways with incision, contusion, abrasion, laceration, puncture, penetration, avulsion, chemical, thermal, irradiation, pressure injury, venous ulcers, arterial ulcers, and diabetic ulcers. Now we do have different types of lesions. We've got primary lesions, which are considered to be like vesicles. They're usually circumscribed and they're less than 1 centimeter in diameter. They can be elevated and they can be filled with serous fluids. This would look like a blister or maybe a chickenpox or herpes zoster lesion. Secondary lesions include scales, where we have a dry buildup of dead skin cells that often flake off the surface of the skin, and they're pretty irregular and variable in size. And this can include some of our fungal infections, psoriasis, or eczema. Another secondary wound would be an ulcer. These are often concave and they produce exudate. They can be deep erosions that involve the dermis and at times go even deeper. And they're pretty variable in size. So then we need to look at the phases of wound healing. We have primary intention. Primary intention is where the wounds or the edges of the wound are closed, or what we call approximated. And this can be done with a dermal glue, with sutures, or with staples. Secondary intention is where the wound edges are not closed or approximated. The wound is going to actually heal from the bottom up, and due to the way it heals, we have increased scarring. And then we have tertiary intention. This is where the wound edges initially are not closed or approximated, but then we close it at a later date. Again, we usually will have increased scarring with this method. Then we need to look at the phases of wound healing. We have that inflammatory phase that's going to last anywhere from 2 to 5 days. The blood clot will form at this point. Platelets are going to start releasing growth factors, and dead cells and debris gather to be removed by macrophages. Then we have the granulation phase, where new vessels and collagen structures form, and the wound is going to be very pink at this point. The white blood cells are removing that debris, and epithelium begins to grow from the wound edges to the center of the wound. In other words, new tissue. And maturation. This is where the collagen fiber remodeling and scar contraction occur, and that can occur over months to years. So, what types of wounds can we have? Well, we can have a clean wound, or we can have a clean contaminated wound. We can have a contaminated wound, a dirty or infected wound, and this would be the type of wound where, let's say we have a fracture and the bone goes through the skin, and now bacteria can get into the wound. We have a partial thickness wound. We have a full thickness wound. The wound can be open or closed, or acute or chronic. And again, we've already talked about the wound healing, and we've talked about the phases of wound healing. Factors that affect wound healing include pressure on the wound, desiccation, in other words, it's become dehydrated, maceration, where we have overhydration, trauma, edema, infection, excessive bleeding, necrosis, biofilm, age of the client, circulation to the wound, oxygenation to the wound, nutrition, the client's general health status, wound etiology, in other words, what happened to cause the wound, immunosuppression, and medications. So risk factors for complications. Hemorrhage, where we have massive bleeding or the development of a hematoma. Hematoma is basically going to be a collection of blood in the tissue. Infection. This can change in wound color, the pain, or the drainage, and is always confirmed by a wound culture. Dehiscence, which is the partial or total rupture of a sutured or closed wound. And you can see an example of that in your slide in the upper left-hand corner. And evisceration, where we have basically a dehiscence, but now we have a protrusion of internal viscera through a wound. So if you look at the upper right-hand picture, you can see the intestines protruding from the wound itself, or a fistula formation. Different diagnostic tests and surgeries that we might do, again, the culture and sensitivity, if we suspect an infection, to help identify microorganisms, and then that sensitivity will determine the effective antibiotic. Surgery can be done to repair damaged tissue or vessels, to close wounds, to help improve ineffective healing. Sometimes we need to debride a wound to initiate healing. And surgical debridement, or an escharotomy. An escharotomy, we're basically removing eschar. This can be done with antibacterial ointments, prophylactic antibiotics, using analgesics for pain, such as opioids and NSAIDs. Alternative therapies. Excuse me again, please. These alternative therapies can include products that contain aloe vera or medical honey and growth factors for wound therapy. When we're caring for wounds, we need to control severe bleeding, assessing for signs of shock, such as a rapid, thready pulse, the skin being cool and clammy, very pale, and hypotension. We also need to prevent infection and control swelling and pain. So as we're beginning to treat that wound, we need to prevent and manage infection. We need to clean that wound and remove any non-viable, aka dead tissue. Maintain the wound in a moist environment, not too wet, but not too dry. We need to eliminate dead space, control odor, eliminate or minimize pain, protect the wound and peri-wound, meaning approximately 4 centimeters around the edges of the wound. And then with teamwork and collaboration, we need to start discharge planning. So what type of wound care needs and related equipment might be required? Are they going to require referral to home health or an outpatient wound care clinic? Do we need to teach the client or caregiver about appropriate wound care? And always involve the client and caregiver in the planning. So with health promotion, we're looking at prevention. We need to manage the topical skin, so what we can see and touch, and manage incontinence. We should position the client with the head of the bed at 30 degrees or less. That helps decrease the pressure on the sacrum and the coccyx, the ischial tuberosities, and also helps prevent shearing forces. We also need to consider support surfaces such as therapeutic beds and mattresses. We need to incorporate pressure injury management, and this is going to involve literally everybody: the nurse, the provider, the wound care nurse, physical therapy, occupational therapy, dietary, pharmacy, and nutritionist. With the nutrition, their diet needs to be high in protein, complex carbs, lipids, vitamins A and C, zinc, and there might be other minerals that we need to incorporate. They need to engage in regular exercise to enhance circulation and teach them how smoking can actually interfere with wound healing because it causes vasoconstriction. And investigate what medications they may be taking that can actually interfere with wound healing, such as those anti-inflammatory medications or steroids or immunosuppressive medications. So how do we actually assess a wound? Well, you have to start by using your senses. First of all, what does it look like? We're looking at the color, swelling, exudate. We have to touch it. Is it extra warm to touch? Is it soft? Is it boggy? In other words, does it kind of squish when you palpate? Or is it firm? Does it have an odor? And in order to determine odor, we can't smell the old dressing because these dressings are going to be staying on anywhere from 3 to 5 days. And in those situations, bacteria is going to start growing and it will cause odor. So we can't assess odor until we have actually cleaned the wound. If there is an odor after we have cleansed the wound, then we can say that the wound has an odor. Then we're going to measure the wound. And we measure the wound like the face of a clock. The head is always 12 o'clock. The feet are always 6 o'clock. Your right will be 3 o'clock and your left is 9 o'clock. We're going to describe the areas of the wound also according to the clock. In other words, we can say we have a particular type of wound bed tissue between 9 and 12 o'clock, etc. When we're measuring, we always start with the length, and length is always going to be 12 to 6 o'clock, so up and down. Then we measure the width, and that is always side to side, so 9 to 3 o'clock. Now, we're not turning that clock to fit the wound. Remember that clock, 12 is the head, 6 is the feet. Then we're going to measure the deepest point of the wound. Now, some wounds are going to be extremely shallow, so it will always have at least a 0.1 millimeter depth or centimeter depth. We're going to place the tip of a cotton-tipped applicator into that deepest part of the wound base. We lay our thumb along the edge and then mark the cotton-tipped applicator with our thumbnail. Keep that thumbnail in place on the applicator, pull it out, then we measure the depth on the ruler. And wounds will always be measured in centimeters. We need to look for undermining and tunneling. This involves us looking at the edges of the wound. Are the edges attached to the wound bed or unattached to the wound bed? So undermining is when part or all of the wound edges are not attached to the wound bed. And to determine this, we take the cotton-tipped applicator and we just basically run it around the edges of the wound. And if it goes under the edge, then we have some undermining. Tunneling is basically what it says. It's tunneling into some portion of the wound bed or around the edges of the wound. So we need to measure where that undermining might be. So is it between 12 and 3 o'clock? Is it between 3 and 4 o'clock, etc.? Again, using the face of a clock as our orientation. We're going to use that cotton-tipped applicator, put it in the deepest part. Again, mark it with our thumbnail, pull it out, and measure on the ruler. Same way with the tunneling. And then when we document, we always document according to the face of the clock. This gives the following nurse who comes and reads your documentation a visual picture of what this wound looks like and where any abnormalities may be found. But always go clockwise when you are describing the wound. Never go counterclockwise. For example, if we say that there's undermining from 12 to 3, that is much different than saying we have undermining from 3 to 12 or 12, 3 to 12. So always go in a clockwise manner. Then we need to identify the wound bed tissue, and we'll show pictures of that here momentarily. But we have 4 different types of tissue, basically. We have epithelial. Epithelial always is an indicator of partial thickness skin loss. It's going to be very shallow, and it's going to be that light pink tissue color. Granulation tissue is a full thickness skin loss. This is where we have beefy red tissue. It could almost look like hamburger. Slough is also a full thickness skin loss, but this tissue is non-viable. In other words, it's dead tissue. It kind of looks like pus, but you cannot wipe it away. It adheres to the bed of the wound. It can be yellow, white, or tan, and it's usually pretty moist. And again, it adheres to the wound bed. Eschar also is a full thickness skin loss, and like slough, this is non-viable tissue. It's dead tissue. It's usually going to be black or dark brown in color, and it can be very hard and dry, but it can also be very soft and moist. The next thing we assess is the peri-wound, and this is going to be up to 4 centimeters around the perimeter of the wound. We're looking at skin integrity, skin color. We're looking for or palpating for induration. In other words, can you feel a delineation in the firmness under the skin? The wound itself should be warm, but is it really warm? We're assessing for edema, erythema, that induration, like I just described. Basically, it's a hardening of the underlying tissues and that varying warmth. Then we need to assess the exudate. Exudate is drainage. What type of exudate is it? How much is it? And does it have an odor? We have serous exudate, which is usually clear, but it may also have a light yellow color to it. Sanguinous exudate is straight blood. We can have a mixture of serous and sanguinous. We call that serosanguinous. And it can either look like a thin, watery blood, or it may just be blood tinged, so it might be just a pinkish color. We can have purulent exudate, which is that opaque or pus, basically. We can also have a mixture of sanguinous and purulent drainage. We need to assess the wound for any signs of infection that would include unusual erythema, unusual warmth, that purulent exudate, unusual edema, and increased pain. And of course, we assess for pain. We're assessing by asking, do you have any pain? Preferably on that numerical scale. We also need to be listening for maybe moaning and groaning or crying, yelling, watching their body language. Are they just grimacing or withdrawing? Is there any guarding of the wound itself? So these are the different types of tissues that I was talking about. In the upper left, You notice we have actually a mixture of two different types of tissue. That light pink color is going to be our epithelial tissue, but that darker reddish color is granulation tissue. If you look at the upper middle picture, this is a good picture of granulation tissue. You notice that really beefy red coloration to it. The upper right-hand picture, this is slough. Notice how it looks like pus. It has that kind of yellowish tan coloration to it. But that yellowish tan coloration, the actual slough is tissue. It's not an exudate, so we cannot wipe it off. We're looking at the lower left-hand picture. This is a picture of eschar. You notice how dark in color it is. This one is almost black, and if you were to touch it, this one would be pretty dry to touch. So if you look over towards 7 and 9 o'clock, you can see that we actually have some epithelial and just a little bit of granulation tissue. So as you're looking at this wound, we're also kind of identifying not only the types of wound bed that we're seeing, but we're looking at the percentage. And in that lower left-hand picture at 6 o'clock, you can see a small area of slough. So I would say this wound itself was probably, let's say 85% eschar between, let's say 10 o'clock and 5 o'clock. And then from 5 to 6 o'clock, we have maybe 5% slough. And then between 6 o'clock and 9 o'clock, we have maybe 10% epithelial tissue. So again, if I were to document it that way, you should be able to get a pretty good picture of what the wound bed actually looks like. And then when we're talking about pressure injuries, which we're going to be doing here in a few minutes, the lower right-hand picture, this is a picture of a deep tissue injury. You see how dark in color it is. It almost looks like a bruise, but it's not really a bruise. That's actually showing tissue damage to the deeper tissues. Wound dressings. Choosing an appropriate dressing is going to be key to helping a wound heal. I stated before, if a wound is dry, it's going to need moisture. If a wound is too wet, then it will need to be dried out. We need that optimal level of moisture to be able to heal. We need to keep it not really wet, not really dry, but we need to keep it moist. The dressing ideally should be able to stay on for an extended period of time. We really want it to be able to stay on for 3 to 5 days. And there's a lot of advanced dressings out there available now that will allow you to keep those dressings on for an extended period of time. We also need to consider that a wound requires optimal warmth for healing. Think about this. After a dressing's removed, it can take up to 4 hours to reach that optimal healing temperature. So if you receive an order for a client to have a dressing changed every 8 hours, you're only going to have 4 hours between those dressing changes where you're actually getting that healing process. So we need to leave those dressings on for as long as possible to actually promote optimal healing. We have a variety of dressings, and I'll talk about some of these dressings. We have dressings that are impregnated with antimicrobials. If you look down at the lower, we have the Hydrofera Blue. This does have some antimicrobials in it, and it's really great for healing some types of wounds. We have silver impregnated dressings that also have that antimicrobial impregnation in the dressing itself. We have dressings with meta honey in it. The picture that you have actually on your slide is going to be more of an ointment that is going to be used with another dressing, but you can also get dressings that have meta honey already impregnated in the dressing itself. We should also use caution when removing a dressing because we don't want to disrupt that healing tissue. So sometimes we can draw arrows on the dressing to indicate the direction of removal. This is really important, for example, when we have like a skin tear and we're removing that dressing. If we remove it the wrong way, we're just going to reopen that skin tear. So if we draw an arrow indicating the direction to remove the dressing, then hopefully we're not disrupting that healing wound. On our dressings, we should always put the date and initial it. That means we as nurses should be carrying a permanent marker in our pocket. We need to be aware that woven gauze, if you look at the picture on the upper right, second from the right, this is a picture of woven gauze. It's that very loosely woven gauze. It can actually leave fibers in wounds. And we don't want the dressing to adhere to the wound bed because it can disrupt the healing wound. In other words, it can basically debride the wound using mechanical forces, and it's really painful. So if it's starting to stick to the wound, we can use like sterile saline to moisten it to help remove it. So let me talk a little bit about some of these other dressings. If you look at the upper right-hand corner, or left-hand corner, I'm sorry, we're using a derma glue to help hold a laceration closed instead of sutures or staples. We have our rolled gauze, and this is really beneficial in helping to secure a dressing to someone, especially if they do not tolerate adhesives very well, which is something else we need to be aware of when we're putting our dressings on. A lot of people will have reaction to the adhesives and they'll start blistering. The upper right hand is the Derma Gel. This is going to be a dressing that is going to provide moisture to a wound that's really dry. The lower left hand, or in the middle on the left hand side, we have some of our foam dressings. These are really great to help absorb drainage, that exudate. We have another dressing that will promote moisture in the middle. And in the right hand lower picture, this is one of our transparent occlusive dressings. And this is just some of them. This is not nearly all of them that are available. We also need to be looking at drains. Drains are going to be placed to remove a collection of fluid in a wound, and they can also help remove dead space in an area where we've removed a large amount of tissue. It's usually going to be placed through a separate opening in the client's skin. We call this a stab wound, and those drains might be sutured in place, which is very common to help prevent it from coming out before it's ready. And then we need to secure that drain in a way that it does not add any extra tension to the stab wound itself. The drains that we're looking at on the left-hand side, this is your Jackson Pratt drain, also called a Reliavac. Just depends on the manufacturer. So basically you squeeze it, close the cap, allow it to fill with the drainage, and then you can open the cap and remove it. In the upper picture, this is what we call a Hemovac. A Hemovac is similar to the JP drain in that you have to squeeze it and close the cap to activate that suction. It can also come with a bag where you can retransfuse the blood that comes from it. These are often used more in your orthopedic surgeries. And then the lower picture on the right-hand side, this is going to be your Penrose drain. This is just basically a flat silicone drain that's placed in the actual wound itself, and then we put a sterile safety pin in it to keep it from sliding all the way back into the wound. This is the only drain that will allow for passive drainage. The other two drains are going to be your active drainage. One drain I don't have on here is a T-tube. A T-tube would be specifically used to drain bile. So use it in the event of a gallbladder surgery. Then we have several different wound therapies. We have a wound vac, which is really great for a large wound or a wound that has a large amount of exudate. It involves putting foam into the open wound, and we need to fill all of the spaces of the wound. Then we cover it with an occlusive drape, and a vacuum will be placed over a small hole that's cut into that occlusive drape and then hooked up to the machine. We can do the hyperbaric oxygen, which is the picture in the lower right hand. You see them in the hyperbaric chamber, and then you see an example of a wound that was healed using hyperbaric oxygen. And then wound debridement. Wound debridement can be done with mechanical beams, such as those wet to dry dressings. When that dressing's removed, it kind of dries out, and it's going to remove underlying tissue. Unfortunately, it not only removes the dead tissue, it also removes the healthy tissue. It's very painful, and wound care specialists consider this type of debridement to be archaic. In other words, it should not be used. But you will still find it being used by several of your providers. Enzymatic debridement is where we use collagenase ointment over the wound bed. It really works well, but it's very slow. We can do biologic debridement. This is going to be your middle picture on the right-hand side, where we put medical grade maggots into the tissue, into the wound, and it will eat the dead tissue. It will not bother the good healthy tissue, and they're really very effective. And then we can do a Sharps debridement, and this is the use of a scalpel or scissors or a curette to cut away any dead tissue. This is what you see in the upper picture, where they're using the pickups to lift the slough, and then they're using scissors to cut away that slough. And then you can see that good, healthy granulation tissue underneath it. Pressure injuries. These develop when blood flow to an area is reduced when the skin is compressed between a bony prominence and the support surface. They can also be caused by shearing forces, which really stresses the need for us to use the lift sheet to pull our clients up in bed. Pressure injuries are very expensive to treat. They result in longer hospital stays, and they increase the likelihood of placement in a long-term care facility and also increase mortality. Risk factors for pressure injuries include immobility, impaired sensory perception, for example, someone who is paralyzed, altered level of consciousness, shear, friction, moisture, chemicals, and some of those chemicals are going to be found in urine and feces. Populations that are at greatest risks are going to be our older adults, those that have a spinal cord injury, those that are acutely ill, they are in long-term care facilities, they've had a hip fracture, or maybe they're in the critical care units. Now, understand that a pressure injury can actually develop in as little as 2 hours in a client that has healthy skin. So imagine how quickly they can develop in someone who has some comorbidities going on. A pressure injury usually will begin as erythema and is a sign that the area has impaired blood flow. Excuse me. If pressure injuries develop despite all preventative measures, we have to assess the stage and then begin to describe it precisely. Only pressure injuries can be staged. No other type of wound can be staged. So a stage 1 pressure injury, this is just basically erythema, that redness. It does not blanch when you press it. You know how you press on your thumbnail or your fingernail and it turns white. And then when you release that pressure, it turns pink again. Well, with a stage 1 pressure injury, it does not turn white. It stays pink. Pressure injuries can be red to a dusky blue in color. The shape is usually going to be irregular and can reflect the shape of the object that's creating the pressure. There may be pain and tenderness at the site with swelling and maybe some hardening of the tissue and associated heat. At this point, there's little destruction of the tissue, and the condition is reversible if we remove the pressure. A stage 2 pressure injury is the only partial thickness skin loss in the epidermis and the dermis. It's the only pressure injury that reveals epithelial tissue initially. Now, the others can reveal epithelial tissue as it resolves, but a stage 2 has epithelial tissue only. The wound is going to be very shallow, and it can appear as a blister that is filled with serum. It can appear like a crack in the skin or an abraded area of the skin. In other words, that skin has just kind of been scraped off. The ulcer can be surrounded by a broad, irregular, and painful reddened area that's warmer than normal. This would be a type of wound that barrier cream would be very effective on. A stage 3 pressure injury, and you can compare these to the pictures below. This is a full thickness skin loss. So with full thickness, that means we have granulation tissue. But it involves damage to the dermis and the subcutaneous tissue, but we have over 50% granulation tissue, meaning we can have other types of tissue involved, but we have to have at least 50% granulation tissue. It's going to be a lot deeper, so it's going to be more of a crater, and it's going to have a distinct outer margin to it. A stage 4 pressure injury is exactly the same as a stage 3, except now we can either see or feel underlying structures, such as muscles, tendons, ligaments, or bone. So again, it's full thickness, it's going to show granulation tissue, but it has to be, the wound bed has to be over 50% granulation tissue. The next type of pressure injury is going to be the unstageable. Unstageable means that we can have epithelial tissue, we can have granulation tissue, but it's going to be less than 50% because with the unstageable, we have a wound bed that has more than 50% eschar or slough. In other words, we cannot completely identify what the wound bed tissue is. And if we were to remove that slough or eschar, we know that it's going to be at least a stage 3 wound. And then, as I was talking earlier, we have a deep tissue injury, which is the 6th type of pressure injury. It's that dark purple. It can also be really dark red in color. The skin is usually intact, and it will be located over a pressure point. We can also have a blister that at one point was filled with serum. So in other words, that clear or clear yellowish fluid that is now filled with blood. That would be a DTI. If that DTI were to open, then we would have at least a stage 3 pressure injury. However, a lot of those DTIs are going to resolve without ever opening. I want you to understand that we can go from a stage 1 to a stage 3, stage 4, etc. Our numbers can get bigger, but our numbers cannot get smaller. So once it's a stage 3, it's always a stage 3 unless it becomes a stage 4. It can never become a stage 2 or a stage 1. If it's a healing stage 3, we would just call it a resolving stage 3. Pressure injuries, like I said, can occur very, very quickly, even with healthy skin and adequate circulation. So we need to know how to prevent pressure injuries. It's really important. So we start off by identifying our clients that are at risk and initiate prevention measures. And one of the tools that we use to help identify those at-risk clients is going to be the Braden scale. The other tool would be the Norton scale. And then the most important thing to do to prevent pressure injuries is offloading. Offloading can be accomplished by several means. Repositioning the client. We reposition them in bed at least every 2 hours. And some clients that are at higher risk may require more frequent repositioning. We position them so they're not resting on pressure points of the skin. We teach clients who are wheelchair bound to shift their weight every 15 minutes if able. Clients that cannot reposition themselves in the wheelchair, we need to do it for them at least every hour. We can also use the offloading devices such as the air mattresses, the boots that have the heel cut out to keep the heel off of the bed, the pillows to put the heels up off of the bed, or to pad those bony prominences. All of those are considered to be offloading procedures. We should also keep the bed linens dry, smooth, and free of wrinkles. We need to keep the skin clean. If they are incontinent, we need to do checks at least every 2 hours. And when we clean them, preferably warm water and a mild cleansing agent. We never scrub. If they have barrier cream on, do not scrub it off. It's on there for a reason. We just clean off what's on top of the barrier cream, leave the barrier cream in place. We may need to reapply some barrier cream, but do not remove the barrier cream. Use moisturizers and lubricants, protective films, barriers, and dressings to help reduce friction and shearing. Those foam dressings have been proven to be very effective in helping prevent pressure injuries. Avoid friction when moving those clients. So again, use that lift sheet. Use trapeze bars if possible to enhance patient mobility. In bed, we want to keep that head at least 30 degrees or lower if possible to reduce the shearing forces that are caused when they slide down in bed. Again, special surfaces for the bed or the chair, those egg crate foam mattresses, static air mattresses, alternating air, gel pads, fluidized air, water mattresses. Sheepskin boots can also help prevent shearing forces to the feet, pillows, other devices, etc. Protect the skin from too much moisture. So using absorbent pads or briefs for incontinence when necessary. Instruct the client and family about risk factors and strategies for preventing pressure injuries. Be aware that some items such as rubber rings, some people think, oh, I've got a pressure injury on the coccyx. I need to put them on a rubber ring when I set them in a chair. It's actually going to increase pressure, and it should not be used to protect areas. They're not actually protective. And provide appropriate nutrition and hydration. Again, we need to increase the amount of protein they're taking in, small frequent meals to improve intake. Supplements of vitamins A, C, and zinc may also be prescribed. This is a tool that was used or developed by the National Pressure Ulcer Advisory Panel. It's called a push tool, and it's used by your wound care nurses to help identify improvement or deterioration in pressure injuries. So we use this tool once a week. We measure the wound. We're going to multiply the length of the wound by the width of the wound, and then match that product up with the appropriate score, how much exudate, and then we identify the type of tissue. Those scores are going to help determine what the push score is, and then we compare it to the previous week or weeks to determine, are we getting any better, are we maintaining, have we stalled, or is it getting worse? And then herpes zoster. It's more commonly called shingles, and it's caused by the varicella zoster virus. This is the same virus that causes chickenpox. So if a client has chickenpox when they're younger, then that virus is actually going to lie dormant in their body for years. And then all of a sudden something triggers it and they have an outbreak of herpes zoster. So it's basically a reactivation of the varicella zoster virus. And those symptoms occur in one or more of the nerve routes. So if you look at the picture, this is kind of the way the nerves the nerve route is coming off of the spine, and the lesions are going to follow that nerve. If it is on the face, it can actually get into the eye and cause ulcerations. It can get into the ear and cause vertigo and permanent hearing loss. And it can actually travel to the brain and cause strokes. One of the things that we see with herpes zoster is pain. We call that herpetic pain or herpetic neuralgia. And they can actually have post-herpetic neuralgia for months or years after the outbreak. And it is really painful. So herpes zoster will occur most often in the older adult and individuals that are immunocompromised. Once you have the shingles, you should not be able to get the shingles again. These lesions are raised, fluid-filled, and very painful. They are inflammatory. Again, they follow a dermatome or the skin that's supplied by that nerve. Lesions are usually going to occur after several days of pain or discomfort, and it may vary from minor irritation and itching to a severe, deep pain. And they can usually last several weeks. That itching and the post-herpetic neuralgia or pain can persist for months to years. Again, they can have a full thickness skin necrosis. They can develop Bell's palsies, eye infections, scarring, especially if they're scratching a lot. We can administer antiviral medications if we administer an antiviral within 48 hours of symptom onset. In that case, it will lessen the severity or maybe prevent additional lesion outbreak and can lessen the duration. Otherwise, we treat it symptomatically, and there are vaccinations which are recommended for people over the age of 50. So as nurses, we discourage contact with people who have not had chickenpox. We can do cool compresses, which are going to feel the best, but if they prefer warm, they can use warm. Loose clothing. If they have those fluid-filled blisters, they need to be isolated, especially from someone who has not had the chickenpox. Once these lesions and vesicles have crusted over and are dry, they are usually not contagious any longer.